Hi, we're in Unit 4G. This is where we discuss the disorders that originate in childhood or adolescence. We're in Townsend, Chapter 33, pages 704 to 742. And some of the topics we'll cover, if you look at your course outline, you'll see that I've changed some of the terminology to better reflect the DSM-5, which came out in 2013. Mental retardation has been replaced by the term intellectual disability. This is a developmental disorder that begins in childhood. Make sure that you are familiar with the levels of severity. There is mild, moderate, severe, and profound. Those are testable concepts, by the way, just, little hint. Autism spectrum disorders used to be called pervasive developmental disorders, and there were a lot of separate subtypes like Asperger's or PDD, pervasive developmental disorder, NOS, which means not otherwise specified. That has been replaced. It's all in one umbrella category, which describes now a wide range of behaviors and functioning. So we'll discuss that. Then we'll talk about ADD or ADHD. And this is another disorder that affects attention and impulse control in children. Conduct disorder, oppositional defiant disorder, which are disruptive behavioral disorders. We'll talk about Tourette syndrome, which is a tic disorder. And then we'll talk about adolescent suicide. So we have a lot of material to really cover in a very short period of time. We will not cover specifically how the various adult disorders, such as OCD, anxiety disorder, bipolar disorder, depressive disorder, we won't really cover those as separate topics, but just be aware that many of the adult mental health issues, including psychosis or schizophrenic spectrum disorders, can occur in childhood. We just won't cover them per se because they've already been discussed in other units. So we'll get started. The first topic we need to address is generally how to work with kids who have mental health issues. And the first thing that I would like you to understand is that it can be very difficult to determine if a child's behavior is quote-unquote normal given their developmental level, or if it signals more of an issue that needs to be addressed. And the reason for that is that growth and development happen very rapidly, but they're very individual, and behavior in children is influenced by their temperament, by their social situation, whether how their family functions, and how their culture determines appropriate behavior in children. So there is a wide range of behavior that could be normal, and then there's behavior that is not normal and can cause problems for the kids. So generally speaking, let's get a list up here on the whiteboard. A behavior is a problem if it's not age appropriate. So we look at developmental norms, go back to your Erikson and Piaget when you work with kids and know what's appropriate and what's not. If it's not culturally appropriate, behaviors that are okay in one culture aren't okay in another. If you have a child who is very stoic and flat, are they depressed or are they from a culture that discourages freedom of expression? And lastly, a behavior is a problem if it causes a significant impairment in adaptive functioning. Now, kids will meet their milestones at their own pace within a developmentally appropriate range. So we go back to the age appropriate. If we expect a child to be able to zipper a jacket and tie their shoes, and they can do neither of those things, or hold a pencil, or read by a certain age, and they can't, that signifies that there's a problem. There are a couple of barriers to identification and treatment. We already discussed how growth and development occur rapidly, and how it can be difficult to sometimes see what's normal from what's not normal. When we do know that there's a problem, sometimes parents are reluctant to ask for help because of the stigma of mental illness. They don't want the label on their child or on their family. And then when you do identify a problem, sometimes it can be difficult to differentiate the symptoms and say, well, this is bipolar disorder or this is attention deficit disorder. Sometimes it can be very difficult to pick out what the right diagnosis is, and the treatment, of course, will vary depending on what we have identified as the problem. It can be difficult to find providers who are well versed in the disorders of children and adolescents. And of course, always at the lower end of the socioeconomic spectrum, people have access to care issues. Okay? So in order to identify, and we know early identification is the key to better outcomes, we need to be able to assess. An assessment of behavioral and emotional disorders, as we've talked about for this whole entire course, is based on communication. So let's talk a little bit about communicating with kids. So I put some of those communication hints down the bottom. Okay, so same techniques, but we want to make sure that our whole therapeutic relationship is based on being consistent and predictable, but at the same time we need to be flexible enough to accept the child for who they are and where they are right now, and we want to allow them to make some choices in their treatment. Our verbal communication needs to be brief and developmentally appropriate. No great big words for little kids. They have to be able to understand it. You want to make sure that your nonverbal communication matches your verbal, that you are communicating, that you are kind and open and not judgmental. Children will interpret any sort of implied judgment as they'll internalize it and make it about their self-esteem. Children a lot of times will think I'm bad or there's something wrong with me. So you want to make sure that you are communicating that they're okay. You want to stay focused on here and now. Children are very present-oriented. And you want to make sure that you're making your expectations clear, you're establishing limits, and you're enforcing them. And this is particularly important with the disruptive behavior disorders and with attention deficit. Children need to know where their limits are, and you need to enforce them. When you are enforcing a limit with a consequence, you need to make sure that your attitude is quiet and non-punitive, but you're firm. And you want to make sure that you're not arguing, that you don't engage in sort of a conflict with the child. It's just, I'm sorry, these are the rules, and then you enforce them. And you want to lastly role model effective communication. For some kids, this might be the only place where they get to learn that skill, is with you in the therapeutic milieu. So make sure that you're role modeling effective communication. The first disorder we're going to talk about is intellectual disability, also known as intellectual developmental disorder, or formerly known as mental retardation. The newer terminology is designed to replace the more stigmatizing terminology of mental retardation, which has been used as an insult to people. Mental retardation, by the way, was a term that was designed to replace terms that were considered even more stigmatizing and insulting, such as moron or imbecile. These were actual categories of functioning under, previous terminology that over time took on that character of being an insult. Some characteristics of intellectual disability. The onset must occur prior to the age of 18. That's what makes it a developmental disorder. It's marked by impairment in either measured intellectual performance or adaptive functioning, most likely both. It used to be defined solely by IQ. Now IQ is one of the criteria. The level of severity is determined by the level of dysfunction across 3 domains: conceptual, which is your ability to learn and to understand concepts; social, your ability to interact with other people in an appropriate manner; and practical. So this would be things tying your shoes, taking a bath by yourself, doing the things that we expect children to do as they develop. And so that is the definition of intellectual disability. So when we talk about the causes for intellectual disability, we're going to look at a lot of things that we sort of discussed in maternity. And about 5% of the cases you're going to see are genetic in your intellectual disability. Some of this is chromosomal, where you have maybe trisomy 21, which is Down syndrome, or you might have Klinefelter's or Fragile X, which is more common among boys. You might have cases of intellectual disability that are related to inborn errors of metabolism, such as PKU disease, where the body can't break down phenylalanine and it accumulates in the brain and causes irreversible brain damage. You might have congenital hypothyroidism. And these are the things that the state screening tests are trying to determine. You also have problems in embryonic development. Now remember, the embryo is that first 8 weeks where every system is developing rapidly. And in these cases, this is about 30% of the time, we have toxicity from, say, alcohol or medications or other teratogens. You can have maternal illnesses and infections that influence the course of pregnancy, x-rays or radiation, complications of pregnancy. So disruptions in embryonic development account for about 30%. Then about 10% are also related to pregnancy, and perinatal factors, birth injury, fetal malnutrition, where there's no blood flow to the baby, the torch infections like toxoplasmosis, rubella, herpes encephalitis. So these other infections, even varicella, chickenpox, can cause intellectual disability. Preterm birth, not all preterm babies are going to get intellectual disability, but preterm birth is associated with the hypoxia that can cause it. So that's your pregnancy and your perinatal factors. Some general medical conditions that can happen in infancy or childhood. We have infections like meningitis. Measles can cause an encephalitis that can cause mental brain damage or intellectual disability. Poisonings, lead poison, insecticides, ingestion of other poisons, medications, or physical traumas, traumatic brain injury in childhood, drowning, very high fevers associated with infections or asphyxiation. So those are some of the medical conditions that can cause intellectual disability in children, and that accounts for about 5% of cases. Then you have social conditions and other mental disorders, and that's about 15 to 20%. And you don't have to memorize the percentages, but that can sometimes be related to perinatal depression or maternal deprivation, where the child is deprived of some kind of stimulation or social interaction. They do not develop normally. It's one of the reasons that we want to treat postpartum depression. Impoverished environments associated with poor prenatal care, and then on top of it, the child does not get adequate nutrition. And then we talk about the severe mental disorders like autism spectrum disorder, which is sometimes comorbid with intellectual disability. So when you add all these percentages together, you still come up with a fair number of cases that are unknown. We don't know what caused the intellectual disability. So those are some of the causes. In terms of describing the impact that intellectual disability can have on a person's life, there are 4 levels of severity. These are determined largely by testing on the Stanford-Binet Intelligence Quotient Test or IQ test, or looking at the level of adaptive functioning that the person has, and that involves looking at their language skills, their ability to perform certain tasks of ordinary living, and their social performance. So we have mild, moderate, severe, and profound, and I would like to look at each one of those individually. About 85% of people with intellectual disability will fall into the mild level of severity, which is defined as an IQ of 50 to 70. Now, it might be very important. IQ testing for young children is not always as accurate as it is later on. And obviously, if the child has an unidentified reading disability, such as dyslexia, they're not going to score well on a test that requires reading. And so it might be very critical to assess this patient carefully. Certainly, this wouldn't necessarily be the nurse's job. It would be the job of an entire team of people. But some ways that we can describe the functioning of a person with mild intellectual disability: they are usually living independently with some assistance. They can be gainfully employed. They might have an apartment and somebody just checks in on them once in a while. Or they may live with a roommate or a sibling. But they can learn to cook. They can learn to take public transportation. Usually their self-care skills, such as toileting, bathing, dressing, are intact in adulthood. They really are usually not very obviously delayed. So this is 85% of your population has a very mild impairment. The key is that they have about a 6th grade education, and so if you are a nurse and you're taking care of a patient with a known mild intellectual disability, all of your patient teaching and reading materials are going to be geared to that person's level. They may function at around the age of 9 to 12, so keep those reading materials at around a 3rd grade level, let's say. This person usually develops social skills with no problem, and there's usually no fine or gross motor involvement. They may have some difficulty with coordination. Usually their speech is fine. But they're just, they're a little slower to learn, and they need some more assistance. And the next level of severity is moderate intellectual disability, where we have an IQ of roughly 35 to 49. And these folks can perform many activities for themselves on the basic level. basic health and safety skills and self-care activities. They can learn to brush their teeth. They can learn to buckle their seatbelt. They can learn to be taught not to touch a hot stove. But you're not going to leave them alone to cook a meal, for example. They might make a peanut butter and jelly sandwich. I mean, it's about what you would expect from a second grader at the moderate level. In fact, educational level at about the second grade. Maybe not times tables, but simple addition, limited reading, writing, signing your name. Communication skills are basic, usually not severe language delays, but certainly not the biggest words. Their comprehension may be at the level of about a second grader. If you're doing patient teaching with somebody who has a moderate intellectual disability, you're really talking to somebody who's in about K through second. They may have difficulty understanding complex social relationships, and so sometimes their behaviors will make other people uncomfortable, and they may have difficulty with peer relationships. This is where, if they're in a school setting, they may need, if they're mainstreamed, they may need somebody to help facilitate those relationships. The motor development is usually intact or fair. As far as what they can do for a living, these folks might work in a sheltered workshop, and they might live in, say, a group home or some other supervised setting. So these are people who need a lot of assistance to function, but they are able to do so on a basic level. The next level of severity is your severe intellectual disability, and these folks have a measured IQ of 20 to 34, but in terms of what their adaptive functioning is, probably a little more descriptive. It's harder to measure IQ the less function that you have. We have considerable delays in all the domains of development. So your motor skills, speech, they are very slow to achieve milestones. They may be trained in some basic self-care, elementary hygiene, toileting. Obviously, these are not the people that you want to, just kind of leave alone for self-care. But they need direct supervision at all times. The biggest risk to these folks is safety. They have no way of keeping themselves safe. They can learn daily routines, but they have very limited communication. They may understand speech, but their ability to verbalize is very, very limited. In fact, when I worked with the developmentally disabled, sometimes you could get very basic sign language where speech, oral speech was difficult. Sometimes you could get them to sign, and it would be basic signs for, like there's a sign for toilet, there's a sign for eat, but that would be pretty much where you were. In terms of where they can live, these are not people who can benefit from any kind of employment or work training. They are usually destined for residential care, such as what we have at Wood Services in Langhorne, or sometimes a group home, which is sort of a single family dwelling that you'll have 3 or 4 people with an aide or several aides living. They do respond to interaction by smiling or vocalizing, but they have no real refined socialization skills. So these are people who need daily supervision and constant support. With one-on-one training, you might get better outcomes in terms of how much personal care they can do, but really, this is a person who's going to need complete care for a lifetime. The last level of intellectual disability is profound, and profoundly intellectually disabled people have an IQ less than 20. Again, the lower you go, the harder it is to actually measure this. So only about 1 to 2% of people with intellectual disabilities fall into this category. So you see, the further down we go, the more rare the disability is. These people have global, serious developmental delays. These are the kids that mom knew something was wrong at 6 months old. This kid wasn't holding his head up. They may have obvious physical or congenital anomalies. They require constant and close supervision for everything. They have no self-care capacity. They may respond to activity. It's sort of those of you who have visited people in nursing homes that have really severe Alzheimer's disease, they'll respond to music or some kind of social interaction, but there's really no meaningful social interaction, no adaptive functioning at all. And really, if these folks can't be maintained with their families, they are headed for residential care. And so that is your profound intellectual disability. So when the nurse is caring for a client with intellectual disability, we want to apply the nursing process. We start with assessment. We want to assess this person's strengths as well as their limitations and encourage as much independence as we can for self-esteem. It's not very unlike dealing with somebody who's older who has maybe a cognitive impairment that's related to Alzheimer's or some other disorder. We want to allow them to have as much autonomy and independence as we can. So we want to assess their ability to take care of themselves realistically. How much assistance does this person need, and can we give them a little bit of room to have some independence? We want to assess their ability to learn and communicate. You know, the person who is pre-verbal or non-verbal may need help. They may understand you, but they may need help with communication skills, and that might be where you have a speech therapist come help you make a communication board, or maybe that client knows a little bit of sign language, and you learn to communicate with this person. If they're in the moderate or mild levels and they're going to be discharged to a more independent setting, if they're in the healthcare setting, you want to make sure that they understand their discharge instructions and the need for their, treatment to continue or their follow-up care. And so you want to assess, are they at a 6th grade level? Can they handle simple reading materials? Are they at that 2nd grade level? And you need to keep everything very, very basic. You also need to include family members in everything you do, or whoever that client support team is, if they have paraprofessionals or other supports. You want to include the people who are going to be taking care of them long term in any care plan you make. And you also want to assess how the family is coping if the client is in a family situation, because caregiver role strain can be a serious issue when you're dealing with chronic disability of any kind. You always want to assess the safety of the environment. If you know that that patient, because of their cognitive impairment or their developmental delay, is at risk for wandering, or is at risk for entanglement, or at risk for aspiration, you're always going to look at the safety aspects of it. So if they're in a home setting or any alternative setting, not a hospital, you're certainly going to assess for any hazards and make sure that that person has appropriate supervision. You also want to assess how that person reacts to the stressor, particularly the client who is hospitalized. The client with severe or profound mental retardation may not understand most of what's happening and may get very, very anxious and agitated. And so you have to learn to communicate maybe through touch or the tone of your voice to let that person know that they're safe. And certainly when there are painful procedures, you might have to restrain the person briefly, such as starting an IV. If they're, a fairly large size client and they have limited cognition, all they understand is that something hurts and they're going to try and fight it. So you need to look at their reactions to stressors in the environment and look for ways to decrease that anxiety. So in terms of nursing diagnosis, once you've made your assessment, remember that each patient is individual, and so there's no set nursing diagnosis for every client who has intellectual disability. It does describe a very wide range of functioning. But we might have some altered family coping. For example, where maybe this is an unexpected diagnosis for a family. Maybe we're expecting a healthy baby and they have a baby who has Down syndrome. So maybe we have some altered family coping. Or maybe there's some caregiver role strain because the individual requires so much care that it's difficult for the family to function. So you might have altered family coping for that. Self-care deficit. Remember, you want the client to do as much as they can for themselves, but you have to identify what it is that they cannot do. Risk for injury related to lack of awareness of the environment, or related to physical aggression, or related to lack of understanding of limits, or impaired physical mobility. So you might have any of those things. Impaired verbal communication. That's something that you're going to want to target, or anxiety related to hospitalization. So these are just sample nursing diagnoses, and again, you're going to individualize whatever care you have based on the client needs at that given time. When we identify the outcomes for a client with intellectual disability, it really will depend on what we identified as our nursing diagnosis, what we found in our assessment. But some sample outcomes might be that the client will remain safe throughout hospitalization, or that the personal care needs will be met daily with assistance, or the client will interact with others in a socially appropriate manner. The client is coping with anxiety. So our interventions are going to also be tailored to our goals and whatever it was we found on assessment. Some sample interventions for a client with intellectual disability could be, for a person with self-care deficit, you might give positive reinforcement for attempts at independence with self-care activities. And then you might assist as required. You can ensure that the environment is safe and free of hazards for the client who is at risk for injury, or maintain supervision at a level that is appropriate. So those are some sample interventions that you might use for people with intellectual disability. And obviously, to evaluate whether your interventions were successful, you go back to your outcomes, and if the client has met the outcomes, if they have remained safe, if they have participated in self-care activities, or if they had all their self-care needs have been met, then you know that your plan was successful. It's time to talk about autism spectrum disorders, and I know that your outline talks about the pervasive developmental disorders, and they want me to cover Asperger's and Rett syndrome, but as of 2013, the DSM-5 absorbed all of those separate subtypes into one umbrella category of ASD, or autism spectrum disorder. And that is what your textbook is teaching, so that is what we're going to go with. The interesting thing about this is that the number of diagnosed cases has increased dramatically in the last 40 years, particularly in the last 20, and it seems like every year they come up with a scarier number. So here's the prevalence, and this is why you can understand that this is such an important thing to learn about. We have 1 in 68 according to Autism Speaks. It's actually according to the CDC as cited in Autism Speaks, but my APA right now is not that fancy. Boys have an even scarier incidence. Boys, the ratio of boys to girls is about 4 or 4.5 to 1 boy for every girl that's diagnosed. So the ratio is very high in favor of boys. 1 in 42 boys across the country diagnosed with ASD. Now, in certain areas of the country, you have much higher proportion of people who are diagnosed. Some of it is thought because you have better medical care and there's more awareness and better diagnosis. Some of that could be because there are better services and people who have kids with autism move here, to New Jersey in particular. New Jersey has a very high incidence. And some of it could be due to environmental factors that we are not yet completely aware of. So autism spectrum disorders are defined in your book as a disorder that is characterized by impairment in social interaction skills and interpersonal communication and a restricted repertoire of activities and interests. Okay, and that kind of mirrors the definition that Autism Speaks has, which characterizes ASD as a group of complex disorders of brain development that are characterized by difficulties in social interaction, verbal and nonverbal communication, and repetitive behaviors. And most of these activities and interests are going to be object-oriented and not person-oriented. And so this person can have very severe, sometimes difficulties interacting with other people. Now, your book also describes autism as a disorder that's characterized by this withdrawal of the child into a fantasy world of their own making, and that's sort of an interesting definition. I think it's kind of old-fashioned. I think that the more current thinking, when you ask people who have autism to describe the world that they experience, what they will tell you is that everything is bright, everything is loud, everything is fast, that they don't understand people, they can't read faces, and so the whole world is confusing to them, and so they withdraw, and they sometimes will have those repetitive interests as a way to self-soothe. Or, sometimes they just get sort of wrapped up in objects that are simple to understand. And Temple Grandin is very interesting. If you ever come across anything she's written, she does talk very elegantly about what the experience of an autistic person is. So, in terms of predisposing factors, we really don't have a cause for autism. All we know is that there is this abnormality. There's some evidence to suggest that there are differences, significant differences in brain structures. The role of neurotransmitters is under investigation, serotonin, dopamine, but really the cause is unclear. Some medical conditions are absolutely linked with autism spectrum disorder, including congenital rubella, Fragile X, which is a disorder caused by deletions on the X chromosome, so that would make sense why boys are more affected, although many parents have had their autistic children tested for Fragile X, and it's been negative. Neurofibromatosis is another syndrome that is sometimes associated with autism, Angelman syndrome. In terms of genetics, there is definitely some evidence that suggests that there is a genetic component. However, it's hard to have a genetic epidemic. So it's hard to explain. There are a lot of families that have never had autism, and now suddenly they have three children affected by autism. But there is a higher incidence among siblings, and twins have a higher concordance if they're identical than if they're fraternal. So there may be some epigenetics that are implicated. And epigenetics just mean that the genes interact with the environment. So something switches on the gene that has autism. And then, of course, when all else fails, we blame mom. Perinatal influences. Women with asthma and allergies in the second trimester had a greater than twofold risk. I've seen other studies that talk about maternal stress and cortisol levels. There are all sorts of things. I've seen research that investigated the link between oxytocin induction and perinatal asphyxia and birth before 39 weeks. And the truth is we just really don't know what causes autism. We do know that it's not from vaccines. There is no credible evidence in the many, many, many studies that have been done in a controlled and ethical manner. No evidence whatsoever that vaccines cause autism. I did read some interesting things about acetaminophen, but again, everything's investigational, and there's nothing really strongly linked other than genetics and certain rare medical conditions. So that's, those are some predisposing factors. Now, because autism is a spectrum disorder, it really does describe a very wide level of functioning. You can have people who are capable of being married and having children and having jobs, as with a lot of our Asperger's or PDD, NOS people who are very high functioning and have high IQs, maybe have some social difficulties. Or you can have people who will need residential care for the rest of their life who also have intellectual disability with autism. And so when we assess it, just because the person has a label of autism spectrum disorders does not really give us the maximum information. We really have to do a thorough assessment. And one thing that we want to note is how well does this person interact socially. So assess social interaction. You might have anything from just a difficulty maintaining eye contact or maybe odd topics of conversation, all the way to kids who completely shut down when they're confronted with people they don't know, rocking, headbanging, that kind of thing. We want to assess communication ability, or ability to communicate. How about we put it that way? Okay, and the reason that can be sort of important. Now, your higher functioning people who have autism are able to verbalize things. They may have oddness in speech. They may have oddness in tone of voice or inflection. There may be an unusual vocal quality, but they're usually able to articulate in very complete sentences. However, they may have difficulty with what's called pragmatic speech, which is speech that's socially directed. For example, they have problems with idioms. They tend to be very, very literal. And so if you use a figure of speech, they might look at you kind of funny because they're trying to figure out what the literal meaning applies to what you just said. They may have problems with nonverbal communication. They don't read body language. They don't read facial expressions. And so they don't interpret social signals. They don't know when they're making other people uncomfortable. They don't feel uncomfortable when they should. Sometimes they can be very naive, people with autism spectrum disorder. Use of gestures might be limited. So the ability to communicate encompasses a lot more than whether or not the person can string together words to make a cohesive sentence. So this is something that you'll want to assess. You want to assess this person's activities and interests. And their tolerance to change. One of the big problems with autism spectrum disorder is that these children and even adults have a real difficulty with any change, any transition, anything that's outside of their familiar routine. And so this can give them a lot of distress. They may have attachment to objects. I mean, objects are big. They're very object focused and not very person oriented, and so our interventions are probably going to try and get them to be a little more person centered. And sometimes these people can get very hysterical. I mean, I'm sure you can all kind of recall a recent experience where you've been in a grocery store and you've seen a kid who was just off the wall screaming for no good reason. And it could be that their socks are scratchy. It could be that somebody flashed a light, or that there was a loud noise that bothered them and they shriek and scream. And that usually is associated with autism. Objects that move or spin is a common preoccupation for people who have autism spectrum disorders. They like fans, anything that spins. Stereotyped body movements or self-stimulating things, flapping, rocking, walking on tippy toe. There's a lot, sometimes spinning in circles themselves. And repetitions of words or phrases. You might get echolalia, which is the repetition, I say something and somebody copies me. Or they might say the whole thing. I knew one kid on the spectrum who could repeat the entire movie of Beauty and the Beast. Every single word. And had the inflection right. Couldn't hold a conversation, but, that was sort of their thing. You might have kids who have real narrow diet interests, people who will, say that their kids only eat chicken nuggets from McDonald's, and they have to be at room temperature. So you have these little sensory things, and you might actually see some self-stimulating behaviors that are injurious, and so you would have to look out for those. So once we've made that assessment, we can make a more intelligent choice in terms of nursing diagnosis. Again, this is a spectrum disorder. Not every person with autism spectrum disorder is going to be at risk for injury, but some of them are. Some of them, now one of the things that goes with autism, and I'm not even sure if your book says it, but there is this difference in sensory processing, and so you have children who are sometimes, not all the time, sometimes they're oversensitive, and sometimes they can be impervious to pain, and so they don't feel the hot stove, or it doesn't really bother them. Those children are obviously at risk for injury. Children with self-mutilating behaviors, the biters, the headbangers, the kids who, as part of their stimming behaviors, do harm to themselves. There can be risk for other directed violence in kids who are older and get aggressive with autism. Remember, there's a lot of anxiety that goes with autism because of the sensory processing difficulties. Impaired social interaction related to developmental disability. It's, your book says related to inability to trust. I don't think that this is an emotional response so much as they don't have the wiring in their brain doesn't allow for normal social cognition. So, and again, this runs on a spectrum. You can have people who just have odd mannerisms. People who are formally diagnosed with Asperger's syndrome might desperately want social interaction, but they're very ineffective at attaining friendships or maintaining friendships because their interests are so narrow that it's really of little. The conversations they have are of little value to other people. So it could be impaired social interaction related to restricted interests. And pragmatic language deficits. So you might have some of those things. Anxiety related to sensory processing disturbance, I included this one because this is really something you might see, particularly if you work in the emergency room. Now, Capitol Health, maybe 2 years ago, opened the first autism-friendly pediatric emergency department, it's a small sort of bay within that department, and there's an attempt to sort of reduce the sensory overload that these children can experience, particularly in that environment. So also impaired verbal and nonverbal communication. These are children who have trouble interpreting cues, nonverbal cues. They have trouble having appropriate affect sometimes. They might have a very, very flat affect. So those are some of the nursing diagnoses that we might use. So some sample outcomes for clients with autism spectrum disorder can be, especially just if we're talking about a client who's hospitalized for some other reason. Patient remains safe. These patients are at extreme risk for injury. So that was our diagnosis, risk for injury, shows no evidence of self-harm, interacts appropriately with one caregiver. Remember, we want this client to become less object-focused and less self-absorbed and more person-oriented and able to interact. Maybe another goal would be is able to initiate, maintain eye contact with a caregiver when prompted. And just so you know, when you go to implement your plan, usually the interventions that are specifically for autism spectrum disorders are really not all nursing. It's a collaborative effort. You're dealing with occupational therapists, special education teachers, speech therapy, physicians. You might have a psychiatrist who prescribes some medication, which we'll talk about in a little bit. But so our interventions, we want consistent caregivers. Here, let me just clear that. So in terms of interventions, some of the things that we can use if we're caring for a client who has autism spectrum disorder, whether inpatient or in some community setting. Consistent caregivers are really helpful as long as we're providing those caregivers with a chance to have a break. Giving the same person to that patient every day can help establish sort of a trusting relationship. Remember, we want them to start to respond to people. Lower the sensory stimulation if it triggers the bad behavior. If there's loud noises that increase that client's anxiety, make sure that things are relatively quiet. If certain tactile factors, scratchy tags in the clothing or something that's too tight or something that has a rough zipper, then we want to remove those things. It's incredible. I have 2 nephews on the spectrum, the things that can set people off if they have these sensory issues. Assess for increasing agitation or anxiety, and then you want to intervene before it becomes a full-blown episode. And then in that sense too, if you have a child who really has difficulty transitioning from one activity to the next, give a lot of warnings. 10 minutes, 8 minutes, 4 minutes, 3 minutes. You want to try and transition them slowly. And provide positive reinforcement when they do the right thing. If they give you eye contact, wow, that was great, or give them a sticker. Find out what it is that reinforces their behavior. You always want to include the family in your care plan, and you want to educate and support that family. Divorce is very common in families that are affected by children with autism spectrum disorders because the caregiver role strain can be incredible. And we want to make sure that the objects that the patient can use to harm self or others are out of the way. But if they're not harmful, if a child has an attachment to some particular object because they have that sort of repetitive or narrow interest, you don't have to upset them by taking it away as long as it's not going to hurt them. But that's sort of how we deal with autism spectrum disorders as nurses. There are some medications that are in use for the symptoms of autism spectrum disorders. It's important to remember that you're not going to see any long-term improvement with the use of these medications. You see really a reduction in the behaviors that can cause problems for the client and the family. There are 2 drugs that are approved by the FDA in the treatment of autism spectrum disorder. One is risperidone, also known as Risperdal. And you'll notice both of these medications are atypical antipsychotics, and we see them in use for a lot of different conditions. The atypicals have application not only for schizophrenia, but for bipolar, for the neurocognitive disorders like Alzheimer's. We might see it in Tourette's. There's a lot of application for these meds. So Risperdal is the first one that was approved. Side effects of Risperdal, just so you know, We can see weight gain, increased appetite. The weight gain that we see with Risperdal is typically abdominal obesity, which tells you that there's some metabolic effects here. If the client is over-sedated, you will see a lot of drowsiness and drooling. They drool a lot when they're over-medicated. So, and you'll also see things like nasal congestion, constipation. With aripiprazole or Abilify, you can see over-sedation, you can see fatigue, you might see that same weight gain. Again, the sugar metabolism can be a little altered, so you might have to watch this client for diabetes, especially if there's a family history. And additionally, you can see tremor. Now, with both of these medications, it is less common, but you can see the effects that you see with typical antipsychotics, meaning the involuntary movement disorders, such as tardive dyskinesia or neuroleptic malignant syndrome is another. Well, that's not an involuntary movement disorder, but there are rare occurrences of this happening with these atypical medications. Hopefully, the doctor or the prescriber is basing the initial dosage on weight and starting off small and only increasing until symptoms are controlled. Now, the kind of symptoms that we look at, again, these are kids who are aggressive, kids who are not benefiting from behavior therapy. Sometimes you'll see the use of these medications initiated in adolescence when symptoms can be aggravated. They are not common. They are sort of a last resort. Then we have some off-label medications, some medications that are typically used for other conditions that have sometimes been applied to clients with autism spectrum disorder. And these might be helpful with clients who have milder manifestations of autism. So we have the stimulants. Sometimes the kids who were formerly known as Asperger's or PDD have difficulty concentrating. They may hyper-focus on irrelevant details of their environment. And they may have difficulty with impulse control. And so the stimulants can help with those symptoms. We sometimes see methylphenidate, which is also known as Ritalin or Concerta or Focalin or Daytrana. There's a lot of different formulations out there. Or amphetamine, which is your Adderall, typically. Some of the other ADHD medicines may be in use for autism spectrum, but these are the ones that came up in my literature search. You also see the SSRIs, selective serotonin reuptake inhibitors. Particularly, you'll see the use of fluoxetine or Prozac, sertraline, which is also called Zoloft, or fluvoxamine, also called Luvox. These medications have been, they have varying effectiveness for things like self-stimming behavior, anxiety related to, sensory issues. But they are in use, and some parents really feel that they're effective. Anticonvulsants have been used in the treatment of symptoms of autism spectrum disorder. The mood stabilizers in particular, you have carbamazepine, also known as Tegretol, lamotrigine, also known as Lamictal. It's an anti-seizure med, valproic acid, Depakote, and topiramate, which is Topamax. And these medications are the ones that are also used for bipolar disorder. So when you have a client whose moods are not easily managed, you might see these medications in use. And one last thing, medications really only address symptoms. So it's really important to stress to parents the importance of early intervention. If you are working in a field where you deal with pediatric population and you will see a lot of clients with various either developmental disabilities or autism spectrum disorders. You'll see different behavioral disorders. Really the key to helping this child maximize their potential is going to be early intervention in most cases, early and effective intervention. And so we want to stress to mom and dad that they have the right to services through their communities, through their public schools. Usually you will need a team approach, including the physician, the nurses, the occupational therapist, the speech therapist, the special education department. And so that is really enough on autism spectrum disorders. The next thing on our agenda is attention deficit disorder and ADHD, which is attention deficit hyperactivity disorder. And although this is commonly thought of as a childhood disorder, it can persist about 60 to 70% of the time into adulthood. And it can, if untreated or unmanaged, particularly in its more severe forms, have very serious consequences for the client. It's a disorder that's characterized by inattention, the inability to focus, and or hyperactivity, which is excessive movement, and even excessive talking kind of falls under that umbrella. The typical description of a child who has ADHD with hyperactivity component is that they are perpetual motion machines. They look like they're running on a motor, or they're driven by a motor. They just go and go and go, and there is no stop. Impulsivity, which is the quality of acting without thinking and not reflecting on the consequences before you do something. And it's very typical for ADHD kids to be like, oh, I'm sorry, and then they do it again. There's no inhibition. And if you follow, there's a Dr. Russell Barkley who treats a lot of ADHD kids, and he says that's really the central feature of ADHD is that there's no inhibition. It's akin to drunkenness in that way. Alcohol sort of relaxes that inhibition, while kids with ADHD don't have it either. And so they do things that they regret because they don't have the brakes to apply to their behavior. The impulses are faster than their ability to stop them. There are two types of ADHD, two subtypes I should say, and then a third that's combined. We have the predominantly inattentive type. These are daydreamers, the ones that are always late for something. They never seem to have their supplies. They are disorganized. You call their name and they don't hear you. They're scribbling on their desk when they should be paying attention. But they're typically not very disruptive. They don't start fights. They don't act out in class. They don't jump up. They don't run around. They're the ones that will sit in their seats and just quietly daydream the day away. When it comes time for a test, they have learned absolutely nothing. We also have the predominantly hyperactive type. And these are the kids who are always running. They have to fidget or tap hands. In fact, as they get older, when they're younger, these kids are running and climbing and jumping in places that are completely inappropriate. They have a hard time playing with other kids because they can't stop their impulses to grab things or take turns, and they just they can't sit quietly. They talk a lot. They blurt out answers. Can't wait their turn. They interrupt other people, and there's a lot of social fallout from being a predominantly hyperactive type. These are the disruptive ones. In a way, they're lucky because they become identified. The inattentive types are typically female. The hyperactive types are more commonly male. They outnumber the females about 3 to 1. But the inattentive types won't get identified as much because they simply aren't enough of a pain in the teacher's butt to trigger an evaluation that could help them and save their academic careers. They just kind of quietly fail out and decide they're not good at school. The predominantly hyperactive type, on the other hand, is always getting someone's attention, and so either it's addressed or the child is punished and becomes resentful. And in fact, about 25% of the people who have ADHD into adulthood become antisocial personality because they feel disenfranchised and alienated with everyone who's in authority over them, and they start to get that attitude that they don't care. We have the combined type of ADHD, and this is probably the most common, and this has types of both, hyperactive type and inattentive type. These are the kids that really, really struggle in school, but they do respond to intervention, so let's get started talking about that a little bit. Okay, before we talk about treatments for ADHD, let's talk about some of the things that predispose people to having attention deficit disorders, and the most important one is probably genetics. Keep in mind this is a neurological disorder. For a long time, people did not believe in attention deficit disorder, but there are structural brain changes associated with it, and these people really do respond to treatment. So, genetics. If one of your parents has ADHD, you are very, very likely to have it. If one of your siblings has ADHD, you are more likely to have it. Identical twins, more often than not, if one twin has it, the other one does too. And this occurs even in children who are adopted and reared apart. They're more commonly found to have ADHD, even if their adoptive families don't have it. It could be related to the chromosome number 16, according to your book. That is also associated with autism spectrum disorder and schizophrenia, which is interesting. But there is a strong genetic component. Now, there's also the possibility of structural brain differences. And we also talk about the role of neurotransmitters. And it's the same big three that we see in, again, schizophrenia, autism, a lot of depression, a lot of the other mental health issues. We're looking at dopamine and norepinephrine, and to a lesser extent, possibly serotonin. So if you have neurotransmitter disturbances, you can have symptoms of ADHD. There are a lot of perinatal and prenatal factors. So let's talk about maternal smoking, because maternal smoking is one of the strongest environmental factors in ADHD. In fact, if your mother smokes and has ADHD, your chances go up significantly. And this is sort of interesting. I'll find a reference for you that quotes it, but one of the links with smoking and ADHD is that people who have ADHD are more likely to use nicotine. There is some neurological connection to that. And in fact, there is a medication called bupropion, also known as Wellbutrin, which is used in both ADHD and in smoking cessation. So that is sort of an interesting connection there. And it's unknown. I mean, if your mother smokes, is it possible she had adult ADHD and she was self-medicating? Unknown. But it is a strong factor. Birth injury and viruses, any kind of environmental insult to the brain can cause, if it hits that center of the brain that controls executive function and inhibition. Fetal alcohol exposure. Now, there is actually a very common personality type with fetal alcohol spectrum disorders. And these are children who just can't connect cause and effect at all. And that is something that you can see in ADHD as well. And in other environmental toxins such as lead exposure. So you see a lot of attention deficit in cities where the paint is kind of old, or there's old plumbing. In inner cities you get a lot of lead exposure, and so that could be one contributory factor. It's important to note that diet really hasn't been proven to affect ADHD that much. I mean, there is some research that talks about food additives, and in Europe, when you take out foods with like red food dye and certain preservatives, sometimes you will see improvement in children. The younger they are, the more likely that is to happen. Now, when we talk about social determinants, this is where, bad parenting does not cause ADHD, but bad parenting can aggravate it. And one interesting thing that you might note is that when children are treated for ADHD with stimulant medications and therapy, parenting tends to get better. That's interesting. So the temperament of an ADHD child often determines the quality of the parenting they get, especially if the socioeconomic status creates a lot of stress in the home, or other factors create stress in the home. Hyperactive kids can be very, very hard to relate to, and they do things that sort of defy good parenting skills. These are the kids that you want to have a good behavioral modification system, but sometimes it fails. They just lack inhibition. So those are some of the predisposing factors for ADHD. And I'd like to talk a little bit about the comorbidities that are common with ADHD, because it really doesn't travel alone most of the time. Up to 20 to 30% of patients with ADHD have comorbid depression, and up to 20% or 25% actually, according to one survey, have anxiety disorder. You can see obsessive compulsive disorder. One therapist that I knew talked about that as the fallout of ADHD. When a person can't seem to control their own behavior, they sort of externalize their source of control, and they have to control everything else around them. Oppositional defiant disorder is very common in adolescents with ADHD. These are kids who are so tired of always being in trouble that they develop a chip on their shoulder. They get very belligerent with any authority figures. It can morph into conduct disorder, which is even more serious. These are kids who are aggressive and can hurt other people, and they have no regard for the rules. These are the ones that are latent antisocial personalities. We have bipolar disorder, very commonly associated with this attention deficit, and it complicates treatment in that the stimulant medications that we use for ADHD can trigger a manic episode. So we have to stabilize the moods before we can really control some of that ADHD. As I said, depression is common with ADHD. Constantly, if you're sort of in trouble or can't measure up to what you're expected to do against people your age who aren't affected by this disorder, you can develop low self-esteem, and that can lead to depression. Substance abuse. Kids who are not treated for ADHD are much, much, much more likely to experiment with other drugs in an attempt to self-medicate. Alcohol use is common. They may experiment with stimulant medications, particularly cocaine, amphetamines, sometimes your MDMA kind of drugs that have like a dual effect, one of which is stimulant. Tourette's disorder sometimes travels along with ADHD, and this is a disorder characterized by tics, and we're going to talk about it a little bit more. Again, that complicates treatment because some of the stimulant medications can aggravate a tic disorder. And specific learning disabilities such as dyslexia or dyscalculia, which is a learning disability that involves mathematics. If you've had some insult to the brain, which sometimes is associated with ADHD, it's not uncommon to have some kind of specific learning disability with that. So these are just some of the comorbid conditions with ADHD, and remember that it can be up to 84%. So these are complicated kids sometimes, and we really have to work hard to figure them out and figure out a treatment plan that works for them. Okay, so when it comes to assessing the child with ADHD, we want to take a real thorough look. We want to definitely compare the child to developmental norms. 5-year-olds will act very different from 8-year-olds. So it's important, if a 3-year-old is running and jumping all over the place, well, that's very different from a 9-year-old jumping on the couch when that's inappropriate. So we want to compare the child to developmental norms and other children their age. And the next thing we want to do, if we suspect ADHD, is a thorough medical screening. Particularly, you want to look at things like vision. You want to look at hearing. Because a child who can't see what's on the board or can't see what's being taught to them isn't going to pay attention to it. A child who can't hear their name being called or can't hear directions isn't going to respond to them. So they can look distractible when in fact they're just missing whatever the input was. And we also want to look at intellectual disability as a possible cause. Sometimes it's very easy. If a child has mild intellectual disability, they might look a little inattentive. Now, most kids with attention deficit disorder are very intelligent. They just have trouble with selective attention. So a thorough medical screening can help rule out other disorders, including autism spectrum and intellectual disability. So then we want to sort of look at this behavior in 2 different environments because it has to occur in more than one element. It can't be situational. So we want to talk to family, and we want to talk to the teachers. A child who is only disruptive at home has a very different problem from a child who is disruptive at home and at school and at Boy Scouts and at church. If the child only exhibits behaviors in one arena, it's possible that it's the milieu that needs to be changed. So those are some considerations. Now, there are certain behavior scales. There are probably many of them, but the most common of them is the Connor scale. I don't think I have to really type that out. The Connor scale is just a listing of statements. My child acts like they are driven by a motor, for example, and the parent or teacher has to indicate whether it happens always, often, sometimes, rarely, or never. And you kind of calculate that score. You use the Connor scale too to evaluate the effectiveness of your intervention, particularly for medication. But that's really some good key points for assessment. And I will get rid of that. And then we can kind of move on to nursing diagnosis. So I have some nursing diagnoses, and they came pretty much from your book on page 718, but they are pretty spot on. We have risk for injury related to impulsive behavior. These are the kids that break their arms because they're jumping off things. They're the kids who, get hurt just because they don't look both ways crossing the street. So risk for injury is a big one. Impaired social interaction, almost break your heart. These kids will try very hard to make friends, but they just can't seem to get it. They understand the social cues, but they can't stop with whatever it is that they want. They have no frustration tolerance, so they melt down if they don't win. They don't like taking turns. They don't like waiting in line. So social interaction can be really, really difficult for these kids. And so social skills training is something we're going to target. Low self-esteem related to negative feedback. If you are constantly receiving stop and don't and no, and you're always the one being punished, the environment seems to be a very hostile place for you. So positive behavior techniques are really important for these kids. And again, the negative feedback comes usually from more than one area. It comes from your peers, it comes from your teachers, it comes from your parents, it comes from your siblings. You just can't seem to meet anybody's expectations with ADHD. If you can't control those impulses and you can't follow directions and you're always doing something inappropriate, there is fallout from that. So these are some really important nursing diagnoses. So for the child that has ADHD, it's important to have a positive behavior modification plan in place. These kids need immediate rewards. It's not even something where you could really bribe them with a carrot on a long stick. It's a lot of stickers and a lot of charts and a lot of good job. Sometimes it's just that verbal praise that they need. Kids with ADHD, unlike kids with autism spectrum disorder, thrive on novelty. So you have to sort of vary the reward a little bit, but you have to be very consistent with rules. And you have to be consistent with your rewards. Negative consequences, a lot of people really like the idea of natural consequences as opposed to punitive parenting or punishment in the environment. And what natural consequences are, it's more or less, well, if you forgot your paper, you'll get a 0. You sort of do, well, this is what happens, and you don't make a big deal out of it. You don't try to embarrass or humiliate the child. That's what sort of leads to that oppositional defiant disorder type behavior. So everything is positive, and yet they have to be allowed to experience the consequences of their actions to learn. And like I said, the positive reinforcement, the stickers, the pencils, as they get older, different privileges, being allowed to go out with friends. That helps. Educational planning, very, very, very important that the school and the home are on the same page. If they aren't, the child gets confused, they feel anxious. So the educational setting also has to have consistent rules and structure. Structure really helps these kids. They do not have an internal structure that helps them plan or attend or learn to inhibit their behavior. So they need external structure. They need routines. They don't have to be rigid routines, but they do have to know what's coming. An agreement between all caregivers about what the consequences are. If one person undermines the plan, it really undoes everything. We also can use family therapy or individual therapy. The individual therapy is useful for the child who has low self-esteem or anxiety issues related to all the negative feedback they might receive in the environment. Family therapy strengthens the family process to help support the individual and give support to parents who are trying to help their child with ADHD. If there's any dysfunctional parenting or family structures involved, this is a good time to address that as well, because chaotic home environments do aggravate the condition. Then we have social skills training. As we mentioned, these kids have poor ability to tolerate frustration. They interrupt. They take things that don't belong to them. They have a problem taking turns. They can sometimes throw tantrums at an age where that's not socially acceptable. So social skills training is very important. We do social skills training with kids who have autism spectrum disorder as well, but it takes on a different character. With attention deficit, we don't work on so much reading people's cues. It's how to do things that are socially acceptable and appropriate, and how to curb impulses. However, we're going to talk now about medical management, because if the child can't pay attention to learn all these techniques, you might be sort of fighting the tide. So let's talk about some medications. And the first of these is going to be stimulants. Stimulants are the most common medication that is prescribed. We already noted that there were some things that you might not want to prescribe stimulants if they're comorbid with ADHD. For example, anxiety. You should get your anxiety controlled, because stimulants can cause anxiety. You might not want to use stimulants in the case of Tourette's as a comorbidity, and the stimulants can also predispose people who have tendencies towards bipolar into manic episodes. So you do want to watch that. Methylphenidate is one of them. That's Ritalin, Concerta, and then we have the various amphetamines. Dextroamphetamine, methamphetamine is actually used therapeutically. Dextroamphetamine combined with amphetamine is called Adderall, so you might know that one. The stimulant medications really are effective. The way that they work is that they increase the levels of serotonin, dopamine, and norepinephrine in the brain, which can sort of strengthen that executive center. They also increase the blood flow to the frontal lobe, and so that inhibition response is strengthened. So the child really gets that time to stop and think about what they're doing before they do it. So stimulants can be a very, very important adjunct to a treatment plan for a child with ADHD. And it's amazing. Sometimes you will bang your head against a wall trying to teach people appropriate behaviors, and then you add a little medication into the mix, and finally they were trying all along to do these things, but they needed that little extra oomph to sort of help them benefit from that training. So those are the stimulant medications. Now we need to talk about the side effects of stimulants, because they are powerful medications and they're giving them to children. So we need to talk about things. Anxiety is a common one. Here, let's get some of the side effects up here, because they're kind of important. For short term, we can see anxiety, some tremors, insomnia, anorexia, the lack of desire to eat. You might see palpitations. These are stimulant medications. They stimulate everything. Blood pressure will usually go up a little bit. If your child is prone to psychosis, or it could be just an idiosyncratic reaction. There have been cases, especially if they're over-medicated, where they can get a little bit psychotic. In the long term, we also look at things, excuse me, sorry, I'm just trying to get some more stuff up there. In the long term, we look at growth and development. It's really, really, really crucial. Did I say really enough times? Do I need to add a star? You're going to see this again somewhere on, probably on ATI or on the NCLEX. But one thing about the stimulants, sorry, move that down too, is that they can stunt your growth. If a child isn't eating, they're not growing. So weight checks, height checks, very, very important. You want to get that medical team assessing this child. They should not be just writing prescriptions. So growth and development can be affected and should be monitored throughout therapy. So that's really your stimulants in a nutshell. The next class of medication that can be used in the treatment of ADHD are your alpha agonists. And this is your clonidine, which is also known as Catapress, and guanfacine, which is also known as Tenex or Intuniv. These are actually blood pressure medications. And the mechanism by which they work isn't completely known. They do decrease the sympathetic signals from the central nervous system. So it's possible they just decrease the motor activity. Now, one thing I will tell you about guanfacine when you're medicating children, it can be very, very sedating. So one of the tips that you might give to parents is to give with food in the evening to minimize daytime sleepiness. But you really do need to monitor. They should be given an ECG before the start of treatment, and their blood pressure should be monitored. Any type of chest discomfort or fainting or palpitation should be investigated because these medications do have cardiovascular effects. It may take 3 to 4 weeks for a therapeutic effect to occur, whereas the stimulants really, you'll start to see things right away. Sometimes the child may have to take a drug holiday from either these or the stimulant medications just to see how they're effective. However, a stimulant you can stop without really any repercussions. Alpha agonist should not be stopped abruptly. It should be tapered, as it can cause cardiac dysfunction. Should not be given to children younger than 6. And you do have to look for signs of dehydration or overheating with this medication. So those are your alpha agonists. Not as popular as your stimulant medications, although Intuniv is growing in popularity, and especially for kids who don't tolerate stimulants, they may be very helpful. So next we have some of the miscellaneous agents. We have atomoxetine, also known as Strattera, and we have bupropion, also known as Wellbutrin. Okay, so atomoxetine does not work as a stimulant. It works on the neurotransmitters and increases norepinephrine. It's a selective norepinephrine reuptake inhibitor, or an SNRI. Now the thing about atomoxetine, it is more effective than a placebo, but maybe not as effective as the stimulant medications. It's also fairly expensive when compared to the stimulants, but it's not a controlled substance, so has less potential for abuse. It does retard growth. The fact that it's really not as effective as stimulants, and it's more effective and has some similar side effects, kind of points in the direction of not using it as a first-line agent and really including it when the child cannot tolerate the stimulant medications. So there's that. Now we have bupropion, and bupropion, or Wellbutrin, is an antidepressant of the heterocyclic class. Not that that matters that much. But it is interesting. It does have other applications. And bupropion works by increasing the levels of dopamine, serotonin, and norepinephrine to the brain. So it works similarly to the stimulants in that sense, but without a lot of the side effects of stimulants. In fact, Wellbutrin tends to be very well tolerated. It is not as immediately effective as the stimulant medications. It can take up to 4 weeks to get results. And, again, maybe does not have as dramatic an improvement in ADHD symptoms, but it is useful for treating ADHD that has comorbid depression or anxiety, where you might not use the stimulant medications. And the big effect with bupropion, again, is weight loss. You can have palpitations, you can have dry mouth, sometimes dizziness, but it tends to be very well tolerated, just not as technically effective as the stimulant medications. And just one last thing to leave you with ADHD. And this is a list of common consequences of untreated or undertreated ADHD. You can have impaired social relationships. In fact, these folks are much more likely to become divorced later in life. Family dysfunction, disruptive behavior disorders. We're already going to talk about ODD and conduct disorder. Emotional disorders. We already talked about the comorbid conditions of depression and anxiety, which are related to low self-esteem. Driving accidents, much more common in adolescents with ADHD, adolescent pregnancy, because there's a failure to plan and a failure to control impulses, academic failures, job failures, substance abuse, and legal issues or encounters with the justice system. So it does benefit us and our clients if we can manage ADHD symptoms. Now it's time to address the disruptive behavior disorders. So we're going to talk about oppositional defiant disorder, or ODD, and we're going to talk about conduct disorder. We've already seen that ODD and conduct disorder tend to co-occur with ADHD. Sometimes they occur alone. And we have to be careful of labeling kids with these disorders because they do sort of set up a dynamic. If people are expecting an oppositional child, they very often set up a dynamic where that does take place. It's important to note that these kids need intervention, and they need consistency, and they need clear limits, and they need structured consequences for violating those limits. Conduct disorder can morph into antisocial personality disorder if it persists into adulthood. And so it's really important to intervene when these kids are still able to change their behavior and their attitudes. So first we're going to talk about oppositional defiant disorder. An oppositional defiant disorder describes a child who is consistently defiant, hostile, negative, argumentative. This child might deliberately annoy their parents or other authority figures just to start an argument, and they can carry grudges and be vindictive and spiteful. Now, it's important to understand that all children sometimes will engage in oppositional behavior. In fact, at certain developmental periods, we sort of expect it. When they're toddlers, they say no and they stamp their feet. When they're adolescents, they want to try and get around the rules. But we don't give out this label unless the child is consistently negative, defiant, hostile, always trying to pick a fight with people. You say black, they say white. That's really your oppositional defiant disorder kid. There are some predisposing factors that have been connected to oppositional defiant disorder. You'll see some overlap with this in conduct disorder. There may be biological basis for this behavior. Kids have unique temperaments, and there may be neurotransmitters that play a role, such as serotonin and, of course, norepinephrine and dopamine, which are sort of always implicated in behavioral disorders and emotional disorders. But that role is not very clearly understood, and we do see a lot of environmental risk factors. Primarily, what you see is inconsistent parenting. Parents might be overly controlling or overly permissive, or you might have one parent who's overly controlling and the other sort of undermines the parent by being overly permissive, and the child learns that the world is not a consistent place, and they have to sort of fight for their rights. Abuse and neglect are extremes of that, where you might have a situation where the child is constantly angry because they're being treated badly, or they're victims of neglect, so they don't respect the authority figures. They've learned that adults are not trustworthy. Family conflict sometimes will lead to oppositional defiant. Children are angry about their living situation, or if there's divorce in the family, they develop persistent negative attitudes towards their parents and other authority figures. And very often what you see is a pre-existing ADHD or some other behavioral or mental health condition that sets this child up for negative interactions with their environment constantly. Their teachers are always picking on them. Their parents are always yelling at them. There's always a consequence. Life is a consequence of who they are. So those kids can develop a sort of persistent negative attitude towards the world and this just sort of angry, defiant behavior. So once you've identified that a child has oppositional defiant disorder, there are a lot of things we can do to help promote more desirable behavior. And one of the things we want to do is to have family therapy, individual therapy. If this problem is manifesting at school, we can get this child an individualized education plan that addresses their behavior disturbance. But we definitely want to take care of both the individual client and teach them better ways to cope with their feelings, and we want to deal with the family to create a better environment and work on the communication skills of all the members. One of the big things you will do with the family, and maybe even on the unit if you're inpatient or residential, is to set limits, and those limits need to be consistent and fair and appropriate. All of the rules and consequences must be clearly communicated in advance. They need to be appropriate, and they need to be enforced consistently, and that is key. If anybody undermines the plan, you're really going to set up a child who learns to sort of split up who's good and who's bad and play one person against the other. You want to encourage this child to take responsibility for their own feelings and actions. No matter what their family situation is, they need to know that they have control over their own behavior. There's a tendency with kids who have ODD and conduct disorder to, because their environment can sometimes be such a negative place, to blame all their problems on other people and to act the part of the victim. And that gives them the right then to act in ways that are socially inappropriate or to express their anger in ways that are inappropriate. The other thing we need to do is to teach actual strategies for dealing with anger. We might need to teach them what to do if you need to take a break, if you need to say, I can't talk to you right now, I need to walk away. Give them some conflict resolution skills. We might need to role play those desirable behaviors so that they have that repertoire that's handy for them when they experience these feelings. And lastly, we really want to reward any desirable behavior. You can't always set up an environment where everything is about the negative consequences. You have to give this child some incentive to act in ways that are appropriate. So that's oppositional defiant disorder. We'll move on to conduct disorder. And the next topic we need to discuss now is conduct disorder. Conduct disorder is very, very serious. Instead of just having an angry, defiant child who still cares, which is what you have with ODD, a conduct disorder implies that there is no respect for the rights of other people at all or societal norms. So you can have theft, assault. These children can engage in criminal behavior. They might be cruel to animals and younger children. Anyone they can victimize. These are your antisocial personalities in training. There may be some biological influences with testosterone or serotonin, and there does seem to be a genetic link. If you had a parent with a conduct disorder, you were much more likely. It does co-occur sometimes with ADHD, but there are a lot of environmental factors that go with conduct disorder. Early rejection by a caregiver is noted to be a risk factor for antisocial personality disorder. For conduct disorder. And in fact, when you see children who have been adopted from countries where they were in institutional care for 2 or 3 years, you do see a very high incidence of conduct disorder. Aggressive behavior that leads to unhealthy peer relationships, your ADHD kid who is a little rough and tumble and violates peer relationships, and then gets peer rejection, will resent the peers and sometimes go into conduct disorder. Kids who were placed in foster care or institutionalized very early have a higher risk for conduct disorder. Abuse, violence within the home, even witnessing abuse, or if there's been serious neglect. Frequent verbal abuse from parents, teachers, or other authority figures to the point where the child either learns to hate themselves or hate other people, or sometimes both. And other family factors, parent with psychiatric illness or substance abuse. If there's a large family size where there's a lot of crowding and poverty, they can learn sort of some bad patterns. There are some physical risk factors that go with it. We talked about the serotonin and testosterone, but also children who've had brain damage or were preterm are more likely to have this disorder. And if they have lower than average intelligence or comorbid learning disabilities, this is more likely. These are the kids that are sometimes insensitive to pain and punishment. So the ones that you spank them and nothing happens, you spank them harder and they still sort of don't react to it. So they learn that, escalating violence is the key to resolving problems. Signs and symptoms of a conduct disorder, you can have people who are just nasty consistently, cruelty to animals or people, vandalizing property, and enjoying that sort of destructive behavior, cheating, cutting classes. These kids have no regard for the rules at all, and any consequence you set, they sort of, it doesn't seem to faze them. They may also abuse other people sexually. They may be involved in crime. And so really this is a child who needs an interdisciplinary approach. They need a consistent approach. And they need intervention before this becomes a long-standing pattern of their personality. So you'll see that a lot of the therapeutic interventions for conduct disorder are similar to those with oppositional defiant disorder. We always need to set limits and be clear and consistent, but our priority intervention goes to safety, always safety first. So we're going to look for escalating anger and make sure that this kid doesn't become physically violent or aggressive with other people. And that could look like verbal threats, or it could look like abusive comments or sarcasm. Again, we're going to look at our nonverbal communication. This is the same as when we look at other clients in the mental health setting. But if you think that there's a potential for violence or for any kind of abuse, you want to make sure that you're keeping everyone in the environment safe. Particularly, you want to make sure that this child doesn't seek out a child who's younger and weaker and use that manipulative behavior to cause harm. You need to have a penalty for manipulative behavior like lying or trying to get other people in trouble for what they do. That has to be sort of separate and beyond your other rules. Consequences for violating the rules of the unit or violating any social norms have to be clear, fair, appropriate, and consistently enforced. It's the same as with the oppositional defiant, only the stakes are a little bit higher for this kid. They will victimize others if you do not do this. So it's really, really important. You have to model appropriate communication and behavior. If this child grew up in an abusive home, this might be the only place where they ever get to see how that works. And that has to pay off for them. So you want to teach effective problem-solving skills, and you want to reward anything they do that's socially appropriate. A lot of these kids will end up somewhere in the system. Unfortunately, conduct disorder a lot of times will result in very young incarceration where they encounter other people with similar behaviors, and that behavior is enforced instead of the more appropriate behavior. So if you can identify conduct disorder before this child does something that violates the law to the extent where they're they encounter the prison system, you can hopefully sort of turn this behavior around and get them to act in ways that are more socially appropriate. So we're going to talk now about tic disorders. We're moving along in our content. We're almost at the end. Tic disorders can be either transient or they can develop into a disorder called Tourette's disorder. So let's talk about what a tic is. A tic is an involuntary, repetitive, stereotyped, meaning it's, kind of odd looking behavior, either a movement or vocalization. So people have blinking tics, coughing tics, they might have like a verbalization where they grunt, they might grimace, skipping, tapping, squeaking, like odd behaviors that are not under voluntary control. Typically we see it beginning in childhood. It can develop as early as 2 years of age, but more commonly right around school age. It is comorbid with ADHD a lot. More common in boys than girls. Tourette's can be a lifelong disorder, but it can diminish over a period of time, usually adolescence or adulthood, and it can disappear completely. Tourette's disorder is definitely a neurological disease. It is not a behavioral or an emotional response, although stress can worsen symptoms. There are some biochemical factors that have been identified. There are differences in the neurotransmitters. The same culprits that, the usual suspects are here: dopamine, serotonin, norepinephrine. We also have some abnormalities in GABA. I'm not going to say that word, acetylcholine. So you might see some differences with those neurotransmitters. There can be structural differences in the way that the brain presents. The corpus callosum in particular is smaller in kids who have Tourette's, and the corpus callosum, if you remember from anatomy, is that structure in the middle of the two hemispheres of the brain that sort of mediates the electrical activity between the two halves. The other brain structures are different in kids with Tourette's than they are in kids with more typical features. When they do studies, they go back and they see that certain things in the prenatal period or the birth period, birth trauma, low birth weight, moms who have hyperemesis, prenatal carbon monoxide poisoning, anything that sort of causes a hypoxic insult to the fetal brain, or the neonatal brain, can induce a Tourette syndrome. And there is like an autoimmune phenomenon with kids who have strep, and I think it's the PANDAS, PANDAS, particular variety of strep. There are a lot of comorbid conditions with Tourette's. You see ADHD is the most frequent one. They seem to go together, and it does complicate treatment of ADHD because stimulant medications can aggravate tics. OCD comes with Tourette's, and you see depression and anxiety. Now, the depression and anxiety of OCD might be a consequence of the Tourette's, or stress might induce both things in susceptible children. Your book says that in severe cases, self-injurious behaviors may be exhibited. You do see kids having outbursts. I think sometimes the stress of living with Tourette's is more than what they can handle with their coping skills at their developmental level. Once a diagnosis of Tourette's disorder is assigned to this client, there are some things that are used for interventions. It sort of depends on the level of impairment this disorder causes people. If it's simple blinking, motor tic, or throat clearing, and it's not too disruptive to this person's life, they might not really offer much of anything except supportive therapy. There is a cognitive or behavioral intervention for tics. It involves like knowing when those tics feel like they're coming on and getting up and moving. There has been some success at reducing the occurrence of tics, but they are involuntary. So stress reduction, sometimes if the child has more tics under periods of stress, we teach them simple ways to manage their anxiety. Supportive therapy is usually aimed at helping the client maintain self-esteem when they have sort of that negative feedback from the environment. It can be hard when you're rejected by peers, or teachers really feel that you're doing this on purpose to bother them, which is a common misconception. And so supportive therapy can help with that. And then there are some medications that are used that are effective for tic disorders. We use the antipsychotics, particularly, let's see if I can alter that. There's haloperidol is one of the conventional ones that's useful. You can't give it to kids under the age of 3. And pimozide is another one of the typicals. Atypicals, the biggest one is risperidone, which we've seen before. They also can use Zyprexa, which is olanzapine, and Geodon, which is also known as iprazodone. And with all of these, you want to monitor for those extrapyramidal symptoms. With kids, you want to be really careful to dose them appropriately, and always use the minimum amount of medication that you need, because these medications can be very, very sedating, and you can really impact growth and development for a child. They can also, the newer agents also cause weight gain, as we know, so you want to monitor. And this is sort of a last resort. When the child's behavior is so disruptive that they can't live a normal life, then you resort to medication. Other medications that are sometimes useful in the treatment of Tourette syndrome are the alpha agonists. Guanfacine, we saw these with ADHD. So if you have a kid with comorbid ADHD, this could be an agent. Now, they still do use stimulants for kids with tic disorders, and the evidence is sort of conflicting with that. But if you combine that with the alpha agonist, your 10x intuitive, clonidine, which is also known as catapress, you can sometimes see a reduction in tic behavior, a reduction in anxiety, and hopefully an ability to focus better if they do have ADHD. SSRIs are used to control anxiety and stress, and they're good for kids who have the comorbid OCD behaviors. So you might see kids with Tourette's on SSRIs, but those are the medications that are used. Our last topic today is adolescent suicide, and I'm just going to put some facts up there. These numbers come from the Action Alliance for Suicide Prevention, and these were published in 2013, so they're fairly recent. Just to give you an idea of what the scope of the problem is that suicide is the second leading cause of death in children ages 10 to 18. About 88,000 children each year are treated in emergency rooms for self-harming injuries. 1 in 13 high school students attempted suicide in 2012, and that's a very high number. If you think about it, you can go into any high school class in America, and 2 out of the 25 or 30 kids sitting there has very likely attempted suicide in the year previous. Females are more likely to attempt suicide, but boys are more likely to succeed, and that has to do with the lethality of the method that they use. Girls are more likely to swallow pills. Boys are more likely to use self-inflicted gunshot wounds. 45%, which is, the biggest proportion of successful suicides, are from gunshot wounds. And so finding out whether an adolescent has access to firearms is a very important assessment for the nurse to make. Excuse me, sorry. The next most common cause is suffocation injuries. 38%, I think, come from that. And then you have other various methods. But the most common is gunshot wounds. So one of the biggest interventions is to reduce access to firearms. So I've listed some of the risk factors for adolescent suicide, and some of them overlap with suicide risk for other populations as well, including the history of mental illness or substance abuse, history of suicide attempts or self-harm in the past, family history of death by suicide. Anyone who's got a family member who succeeded in committing suicide is at higher risk. Kids with social isolation, kids who have been bullied, or kids who have perpetrated bullying on other people are at much higher risk for suicide. So stopping bullying is one of our interventions for preventing adolescent suicide. A history of trauma or any kind of abuse, any involvement with the criminal justice system, foster care, residential facility, these kids are at much higher risk. Kids with impulsive, aggressive, or reckless behavior can have self-directed violence. The big thing that we can help with is access to lethal means. So when you do your suicide assessment, you ask the person, are you thinking of hurting yourself or killing yourself? And if this young person answers that they are, you have to ask them what their plan is. If they tell you what the plan is, you should ask them if they have access to the plan. One important thing, you're always going to assess firearms. Firearms are so lethal that, one impulsive mistake, there's really no coming back from it. And this is why boys are more often successful, because they more often attempt by firearms. Girls will usually swallow pills or cut themselves, and you have a little bit of time to intervene, but a gunshot wound can be very immediately fatal. Kids who have relationship problems, break up with their first boyfriend, girlfriend, whatever, or if they have unstable relationships with their families, they're at increased risk for suicide. So these are some of the things that we may want to assess in patients. Some of the protective factors that can prevent suicide are very similar to what you would see in an adult. But easy access to effective treatment for underlying mental health and substance abuse disorders is very important. Getting parents to be able to access care and increasing the availability of these services. Problem-solving skills. When we allow children to learn how to solve problems, they're less likely to see their temporary problems as hopeless, and they're more likely to seek alternative solutions than suicide. Cultural or religious beliefs that prohibit suicide can be very important in preventing suicide. So reminding the client of their religion and assessing that and seeing if that is something that might help them look at other solutions. Supportive families are very important in connectedness to the community. People who have larger social networks are less likely to commit suicide. A positive school experience for adolescents is so important. So protecting them from bullying, protecting them from severely negative reactions with teachers, putting them in a positive school experience sometimes is very, very protective against adolescent suicide. And maybe one of the more important ones is lack of access to lethal means. This is where you want to educate people about their firearms, never keep them in readily available areas. Don't allow your child access to medications they can use to overdose. These are some of the protective factors, but nothing is 100%. A person who is really determined to kill themselves, unless they're in a treatment environment, can usually find some means. These are some ways that we can prevent against suicide. There are some behaviors that indicate that children or adolescents are more likely to attempt or commit suicide. And one of them is unusual or sudden changes in behavior or mood, when their personality changes dramatically. they may become more withdrawn, or they may become more angry or aggressive, but that sudden change in behavior or mood can tip us off. Changes in sleeping behavior or eating, and you might see insomnia, or you might see kids who want to lay in bed all day. Changes in eating, sometimes they don't want to eat and they lose weight. Other children will overeat, and these are all symptoms of major depressive disorder too. But the big tip-off is what they say. They talk about they wish they were never born, they want to die, they make statements such as nobody cares what happens to me, or you'd be better off without me, or I can't take it anymore, or it's okay, this will all be over soon. Those statements need to really raise some red flags and get a response right away. Withdrawal, like I said, from friends, family, activities. Expressions of hopelessness or feeling trapped, and a child who starts giving away prized possessions. Is usually indicating that they might be getting ready, particularly if you have any of the other risk factors, or if your child has attempted suicide in the past. This client needs some intervention pretty fast. So if we suspect that an adolescent is planning or contemplating suicide, we need to do a thorough risk assessment that is very similar to the risk assessment we do in adults. We have to be very, very direct. The reason that adolescent suicide can be such a problem is suicide is an impulsive act. Adolescents are impulsive people, and an adolescent who has access to very lethal means is a very risky situation. So we want to ask them directly. This is one place where you don't want those open-ended questions. You don't want any room for ambiguity. Have you thought of hurting or killing yourself? And a yes answer prompts a bunch of other questions. How strong are those thoughts? How often do you have them? How long have you been having them? Have you thought about how you would do it? Is there a time frame? Have you been planning to get access to the means? Do you have a way to get the gun? Do you have the pills? Do you have a way to get the pills? All of those questions are going to tell us the relative risk to this patient, but most likely any yes answer is going to require immediate intervention. You're going to have to enlist the help of the parents. Parents do have to be notified if an adolescent verbalizes self-harm. Most likely they're going to have to be kept overnight in a crisis type situation. Once they're released from crisis care or immediate hospitalization, short-term hospitalization, follow-up in the community is very, very important to make sure that these clients get their coping skills and that we can prevent them from self-harming. So cognitive behavioral therapy is good. Is a good intervention to use with an adolescent who is at risk for suicide. Helping them with problem-solving skills so that they don't feel that their situation is hopeless. Strengthening the family. And educating parents on removing access to lethal means, particularly firearms. And also sometimes if there's major depressive disorder, so we'll say treatment of mental health conditions, depressive disorder or bipolar disorder, which may require some medication support. These can be important ways to prevent adolescent suicide. And that really concludes our material for Unit 4G.